dabigatran was the only NOAC which was available even in the Western world. And earlier, I must say as well, so I was more exposed to the warfarin and we were using warfarin. So it was a little bit surprise to me, but with passage of time, I got used to it. And in fact, in 2014 as well, my boss, Professor Harry Cranks, asked me to compile the comparative data for dabigatran, warfarin, and rivaroxaban, which we published it in International Journal of Cardiology in 2014. And later on, in fact, the editor asked to add up rivaroxaban as well. So that's the paper which you can see it in the below one, which is even referenced in the expert consensus document on AF ablation, other than my ATSCA paper as well. So that had been the time, and since then we all are aware there has been a lot of additions, in fact, about the options of NOACs. NOACs is being used not just in the Western world, but I think even globally as well. Even while practicing in Delhi, while practicing in Patna, or visiting northeast like Assam, Guwahati as well, or even towards the south, I really felt glad that India has been progressing well, and the usage of NOACs has been progressing well for the patients. Then comes the another problem. When we start to use the NOACs, what about its problems associated with that? So this is my latest paper. I'm sure you all will be aware of the European Heart Rhythm Association conference, which is already going on right now. My paper of again the latest NOAC as well. We try to compare it with the other anticoagulants as well in the subset of atrial fibrillation patients. So if you all are interested, I have already shared the link in the chat box as well. Please go through that, and definitely we can talk about it later on. So as I was telling, with growing popularity and growing usage, it becomes the responsibility, our responsibility. What about its problem? So is it possible, to, for example, to reverse it? For example, if there is a bleeding complication, if there is a if we get a call from our patient that okay, our patient had been using this medication and the patient developed some complication, how are we going to take care? And that's where I think we all can recall the movie from Spider-Man. With great power comes great responsibility, isn't it? So that is where we all have to think, what about the chances of reversal? So we all are very much aware that for dabigatran, yes, there are reversal agents, and I will try to also talk about the different landmark trials and also some of the Indian case scenarios as well. And as I already said it, anticoagulation care has been really progressive and has been making huge inroads, and also the developments, the milestones has been tremendous. Not just from the progression, as I said it myself, like till 2010, the options what we had was warfarin or the vitamin K antagonists. Then came the NOACs, and the ultimate level, I would say, is the usage of reversal agents. So, we all are aware that dabigatran with idarucizumab is the first and only NOAC with a specific reversal agent. In fact, what happens is it's a monoclonal mouse antibody which was developed with high dabigatran binding affinity, and idarucizumab is the humanized Fab fragment expressed directly in the hamster cells and produced in-house. In fact, so as you can see at the molecular structure over here, there are two segments. So one is the Fab region, and this is the FC region which is removed. So the Fab region is the one which is the part of the antibody which will go and bind to the dabigatran over here. Okay, so this is like a lock and key mechanism, so which will be going and binding. And the other region which is removed is a structural element which interacts with the immune system. Okay, so when we look at its characteristics, it has plenty of characteristics. It's not just a humanized antibody fragment, but it is also a dabigatran complex which is eliminated quickly. So it's not like this, if we give this antidote to any of the patient, it is going to be remaining in the body for like long hours or long days. No, within few hours it will be eliminated as well. There's no endogenous target, and it is easily and ready to use solutions are available for IV administration. So therefore, the onset of action is quick, and the binding affinity of dabigatran is nearly 350 times. So it's very, very specific. So its affinity to be able to bind only to the dabigatran is quite a lot specific. So even while we compare to like thrombin, 350 times is a huge. And I think more is the number of times, better it is for the specificity. And that's the reason due to which we get essential irreversible binding. And specific to the dabigatran, it is because, as I said, it is due to the higher amount of specificity, and in fact, it does not reverse heparin or any other anticoagulant. So even when we are trying to use this NOAC reversal agent, still heparin can be used, and yes, there are no endogenous target. So there are several clinical studies which has already been done. This was among the most prominent studies which came in New England Journal of Medicine, which is considered as the Bible, I would say, for all our medical fraternity colleagues everywhere in the world. So the first one of these studies was Reverse AD. So the objective of the study was to demonstrate the extent of reversal of the anticoagulant effect of dabigatran in patients who have uncontrolled or life-threatening bleeding, and in those requiring emergency surgery or invasive procedures for which normal hemostasis is desirable. And it was not that it was done just in 1 or 2 or 5 countries. No, nearly 40 countries with more than 173 sites were recruited, with a population sample size of nearly 503 patients. Okay, so it was aimed to demonstrate the extent of reversal of the anticoagulant effect of dabigatran in patients who have controlled or life-threatening bleeding, and in those requiring emergency surgery or other invasive procedures for which normal hemostasis is desirable. As you may notice over here, there are two groups, which is the group A with uncontrolled bleeding, and the group B is the emergency surgery or procedure, which has already come to the hospital. For example, if there is a surgery which needs to be done like orthopedic surgery, but the patient has been on dabigatran, then what do we do? So within 0 to 15 minutes itself, the primary endpoint will be met, which is the 2 into 2.5 grams of the idarucizumab will be injected IV, and so that the maximal reversal is going to happen within 4 hours. Okay, and the secondary endpoints, of course, we try to see for the thrombotic events, the restart of anticoagulation, how about the mortality, and also the drug levels, and also the immunogenicity as well. Okay, so as we can see it over here, the results wise among the two groups, as we can see, the first group, Group A, consisted of nearly 60% of the patients, and the Group B is the one which consisted of nearly 40% of the patients. It's always interesting to go through the patient characteristics, not just they were similar in terms of the age-wise or even the comorbidities-wise as well, even the dosage of dabigatran, how much they had been using, or when was the last time as well this was being used, or the different bleeding parameters as well, they seem to be pretty similar. So when we try to focus on the major bleeding events, especially in the first group, so we can really notice over here, majority of the patients had intracranial bleed. Then was also the gastrointestinal bleed, and the not so frequent or less frequent were ones like the intramuscular, retroperitoneal, and all as well. Yes, a lot of these patients were associated with, I would say, nearly 38% were associated with hemodynamic instability. In fact, 1/5 of them needed surgical intervention. And in fact, the quarter of them was trauma related. And yes, majority of them had a major and life-threatening bleeding in fact, up to 90%. So if we will look in this slide carefully, especially for the Group B, we may notice that of the 202 patients with emergency procedures, 82% underwent non-cardiac interventions. Yes, cardiac interventions are important, but acute abdominal bone fractures and other problems as well, they do have a very important life in day-to-day scenario as well. So, while trying to compare about the usage of reversal agents in the different groups, as you may see about the timing, the group A did have nearly 300 patients, and as I already said, it is in the emergency surgery or procedure group, the total number was around 195 patients. So, if we try to look carefully, that after when the dosage was given, they were monitored according to DTT, in fact. So DTT, what does it stand for, is diluted thrombin time. And they also kept on monitoring the dabigatran levels as well. So as we can notice over here, the highly majority of the dabigatran really came into well control in good amount of time, and that was immediately after giving the injection of the reversal agent. And same thing even applied for the group B as well. So indeed it shows indirectly about its effectivity as well, about the usage of reversal agent. So it's not like this that you just leave it for some time and it goes and disappears on the body in its own. No. So there is definitely a big role for the reversal agents as well. And in this, as we can see in the type B patients, while trying to compare, on an average 2.5 hours, 2.5 hours was the time, from the median time of giving to the bleeding cessation. So this is very, very important as well. Like, up to how much time can we expect? Like, if there is a critical patient, we have injected the reversal agent. So up to how much time can it take for this? So similarly, for the hemostasis, when they try to see, the hemostasis parameters were much better. In fact, the average time was around 1.6 hours. So this was significantly lesser as well when they try to compare it with the other groups. So to summarize the results of this study, in fact, just 5 grams of idarucizumab was very effective. It was complete in its action, and there was a sustained level of dabigatran anticoagulation stopping as well. In fact, on an average, a median time, for the extracranial bleed was around up to 2.5 hours. However, the median time to surgery after the reversal was nearly 1.6 hours in majority of the group B patients. And coming to the adverse effects or safety concerns, there were no major issues. We all are curious, how about it, some local scenarios and all? So there are some two beautiful case reports which I would really like to share. So this is one from Mumbai. So what had happened is there was an elderly female patient who did have a fall and presented with intracranial, intracranial hematoma and hemorrhage, and nasal bleed was also there, and became unconscious, of course, due to the fall. And the patient had been taking 110 milligrams BD. And as I said it, the hematoma was further confirmed also on the CT scan. So emergency surgery was planned for the clinical benefit of the patient, and immediately the reversal agent was administered, and within 48 hours itself, not only the speech improved, in fact, the hematoma size increase was not at all seen. In fact, surgery was avoided. You can imagine the surgery being an invasive procedure as well, with someone being on anticoagulant, it can be catastrophic, in fact. So luckily, the surgery could be avoided for the patient, and the low molecular weight heparin was started on the day 5. And when the CT scan report was repeated on after 2 months, there was no hematoma at all. So a complete regression was noticed. And to tell you everyone on a good note, the patient was restarted on 110 milligrams BD dosage. This is another patient again taken from Mumbai. was a younger, relatively younger, I would say, female patient. Again had a stroke, and after that, the clinical history was the patient was of atrial fibrillation, again on the lower dosage of dabigatran, and after the APTT was of 38.7 seconds, which was noticed, immediately within 1 hour of admission, the reversal agent was injected, and later on, in fact, the patient was thrombolized with Actylize within 3 hours of the symptom onset. So not just it caused the reversal of the NOAC, like dabigatran, for which the patient was on. In fact, on the other side, even thrombolysis was also done, okay, for the stroke. And later on the day two itself, power in the limbs was really normal, and within 2 weeks, the patient was not only discharged but also sent to the home as well. So, one of the common question comes always to our mind is, when should we consider reversing the anticoagulant? So I think being clinicians, for us, always the acuteness of the situation is the most important. For example, if someone has to undergo acute abdominal procedure, a neurosurgical procedure, or even cardiac surgery as well, and similarly, otherwise there are sometimes unwanted events happens, like the life-threatening events like the intracranial bleed, or even the intraocular bleeding as well, or sometimes even the closed space bleeding, for example, the retroperitoneal bleed, pericardial bleed as well, otherwise some ongoing bleeding which is already happening. So that must be taken care of. So that really adds up to the situation for us to take care. And even we are aware that I think Dr. Roy has already spoken in his lecture as well, how to titrate the dosages of NOAC, especially whenever the renal functions are compromised. So if we are trying to, initiate a surgical intervention on an acute basis, so we should be also aware what about the usage of reversal agent as well for such kind of drugs. So then once if it has been done, so for example, there's immediate and complete hemostasis, there's a atraumatic or spinal epidural anesthesia, or even clean lumbar puncture, nearly 6 to 8 hours of surgery, a NOAC can be started. Similarly, and the procedures has been associated with immobilization. So then one must initiate a reduced venous thromboprophylactic or immediate dosage of low molecular weight heparin, which is nearly 6 to 8 hours after the surgery. Okay, so it is really important, as I have said, it is to initiate the NOAC 48 to 72 hours after the surgery. Okay, and there are in fact the guidelines. So this is the again guidelines from the EHRA, European Heart Rhythm Association, which I said it that one of my papers is already there. In fact, just few days back, which has been accepted. In fact, there is another one as well, which I'll be sharing in the Heart Rhythm Society. Possibly, I think in June or July, it should be there in US. Hopefully, when we speak about the next time, then we can talk about it in more detail as well. So there are guidelines. For example, if there is a patient on a NOAC and the patient presents to us with a bleeding, so first of all, we should try to ask is, when was the last NOAC which was taken? Okay. Then we should try to get some blood sample to try to see for the creatinine clearance, as I already said it about it. Then also to investigate about the hemoglobin and also the white blood cells. We should also try to see or inquire about the rapid coagulation assessment, because as I had already said, it is ACT or the traditional coagulation assessment may not be the same for the NOACs. So it's always good. So, and then we can further classify into mild, moderate, and life-threatening bleeding. So this is a beautiful paper from Heidbuckel. So Heidbuckel, I really remember. So he's a leading professor in EP, electrophysiology. He was initially based at Leiden University, and I think just few years back, like I think 2 or 3 years back, he moved to a Hasselt University in Belgium. So Hasselt was in close proximity of Maastricht, where I did my doctorate training and also did my EP fellowship in like 2010, as I had said it earlier. So Dr. Heidbuckel says that we should try to classify it into mild, moderate, and severe bleeding, or the last one, of course, is the life-threatening bleeding. So for the mild bleeding, we should just delay the dosage, whichever dosage which we are giving. Otherwise, if it is needed, just skip that dose. However, if it is moderate or severe bleeding, of course you should stop the dosage, and then you may need to give supportive treatment, supportive measures like the mechanical compressions. You may need also endoscopic hemostasis as well if you come across that, okay, there's a GI bleed, and sometimes RBC transfusion, or even fresh frozen plasma, or even platelet transfusion also may be helpful. And yes, if the patient is on dabigatran, so you can give Idarucizumab like 5 grams in an intravenous way, and always try to make sure that adequate diuresis is being maintained. And even after that, if it is still becoming difficult, then one may consider for hemodialysis. And as I had already said it, if it is life-threatening bleeding, yes, other than the previous steps which I said it, you should try to consider for the PCC, which will be of around 50 units per kg, and if needed, repeat the half of its dosage as well. Okay, so to tell you, we are also aware that there are some other additional reversal agents as well. For example, Adnexa alpha, which is available. However, we should try to keep it in mind is it's tends to target the factor 10 inhibitors and the heparin. Okay, so it will not only inhibit the action of the NOAC but also the heparin as well. So one should be extremely careful for that. And in fact, it's not widely available. So I do practice my medicine in UK as well. I'm a licensed doctor over here, and also in India. So even in UK or even in Netherlands as well, where I had practiced, Netherlands per capita wise is one of the richest countries in the world, even comparable to Switzerland and all. Even in those countries, I'll tell you, it can be difficult to make the availability of Adnexa alpha, leave alone US. So what I mean to say is, and in India it is not at all available, let me tell you, or even in South Asian countries as well, even some of the Middle East countries, sometimes where I do visit, they have been having problems in making sure it is available. So yes, it's great to use the other NOACs, but problem will happen. And in fact, when you think about its reconstitution, several times many vials will be needed. Of course, first thing is availability is a problem. Cost itself is exorbitant. And even if you're trying to use, for example, Idarucizumab, if you're trying to use, yes, okay, with the 2 ampules, it will be done. But when you're trying to use Adnexa alpha, you may need several, as I said, vials as well. And regarding its approval, we all are aware that there has been delay of like 1.5 years compared to the Idarucizumab. In fact, as well, the price is also much lesser. And as I already said it, it's about its bolus infusion as well. It can be difficult. So it does have a lot of several theoretical advantages, but on practical grounds, it can be quite a lot difficult. So as I said it, while trying to compare both of them, they are still not yet approval yet in the emergency surgery for the Adnexa alpha, and this one For example, even after after stopping the dosage, multiple vials may be needed, infusions may be needed, in fact. So it's not like this that, for example, for Idarucizumab, in which you just take the 2 into 2.5 grams of this, reconstitute it, and just give it done. No, you have to give it like an infusion, and that's the reason, as I said, it is one may need is multiple vials. So, and yes, it does have potential prothrombotic effect as well, and as I had said it, it also reverses the action of heparin. So you have to really wait for quite a lot of time, and in countries where resources and price can be a huge concern, it can be a bit difficult, and we have to be also careful about the practical considerations. So thank you so much for your patient hearing, and I'll be more than happy to answer any of the questions if there are any. That's a very good question, Dr. Uja. Thank you so much for asking this question. I am aware, I was there I still remember, we had plenty of meetings around, I would say, like mid of February 2018 to be precise, when dabigatran became a generic drug. And so there were more than, I think, if I recall well, 34 pharmaceutical companies which launched it. So India is a great country, okay, where we tend to have is process patent, not product patent. So globally, product patent is what is respected. So if someone can make arrive at that product going through some different process, one will get a patent. Yeah, and one can make it claim it to be different. So, for example, I think we have a great audience over here. Uh, Most of them, if given a choice, we tend to avoid, I would say, non-branded products, right? For example, when we drive a car, we would like to drive a Honda, we would like to drive a Suzuki, we would like to drive a Mahindra, not a car which will be manufactured by some unknown company. For example, watch as well. If we want to be using its Titan, we want it to be a Tissot. Otherwise, even earlier days, there were other brands and all as well. So what I mean to say is, lot of R&D goes, specialized research and development, which may not be visible to others. Yes, they may claim to be having the similar bioavailability. They may claim, others may claim that, oh, we have make it really similar. So from outside, it may look very similar. But on the molecular level, our body is very sensitive. The percentage of the bioavailability as well can be a huge concern. So my friend, when you are trying to consider for the morbidity and mortality, believe me, having a stroke, having a embolic episode in the body is more disastrous than few thousand rupees, I would say. So I always try to believe when it is the matter of the life and death, when it is the matter of morbidity and mortality, when we are considering, please try to consider for at least a good one. And so that is where the difference of the real generic and the not so real generic happens. If I will ask you, as I said, it is, will you try to buy a Chinese watch which is there on the road? See, that Chinese watch will also show you time. That Chinese watch will give alarm as well. It works well. So even, for example, mobile phones as well. No one would like to buy a 2000 or 2500 rupees watch. Everyone would like to buy a Samsung or Xiaomi, for example, or a good brand. So what I mean to say is, It may look, yes, that generic it is there, it is pretty much similar, but no, not everything is same. In fact, what is called as pharmaco equivalence as well on those kind of parameters, it may be slightly different. And a lot of times, as you saw that fragment which I showed it to you, which has to go and get attached to the dabigatran, sometimes may be problematic. Okay, I must say on ground realities I couldn't use it for any I would say no the generic dabigatran. I couldn't use it. I have used it successfully for the original dabigatran molecule, but not for the generic ones. But I still do have my doubts, and as I said, it is due to all these parameters. So I at least really try to avoid using it. And I must say to Dr. Oja, now there are several non government associations, non government organizations, which will even try to make them available the reversal agent for free if someone gets registered with the original dabigatran molecule. So I would really recommend to, for example, for all our physicians to look at the longer picture. The complications, the need for a reversal agent may be very less, okay? The percentage may be very less, but believe me, that life can be disastrous. It's not a good life when someone gets a bleeding complication, when someone gets a stroke. No, no, no. So I would really like our colleagues to be a little bit more considerate whenever we are thinking of the patient on the other side of the table. What if that person is our family member? Would we like to? So that's what I would say. Let's try to be a bit more considerate whenever we are thinking of starting someone on any of the NOACs. I hope it answers your question, Dr. Oja. Thank you so much. Any further questions?
For it actually, and patient had survived. Patient had surgery, so emergency neurosurgical procedure was done. So I believe that probably this product works as well in the generic variety of